Good morning, everybody. Thank you so much for attending this webinar. My name is Andrew Murtha. I'm at Johns Hopkins SAIS, where I'm a professor. But more importantly, for this event, in any case, is I'm also vice president for of the Center for Khmer Studies, and I'm couldn't be happier to be here and to be part of what really is going to be a fascinating talk. And so what I'd like to do is just introduce our speaker and then step aside. What I will ask people is if you have questions, please put them in the Q&A. And after Professor Xiang is finished with her presentation, then we'll go through the questions. So Tiffany Xiang has a doctorate in human and economic geography. She is now a postdoctoral scientist in social science at the Institut Pasteur du Cambodge, and her research explores territorial, social, and health dynamics in rural and forest communities, where she focuses on public health, emerging infectious diseases, zoonoses, and vector-borne diseases. She co-leads the Roxme One Health and Virage Rabies studies on the social science component of those studies. And she has also contributed research on forest malaria and antimicrobial resistance, emphasizing local social behaviors and health challenges in endemic areas. In fact, she just got back from the field not that long ago. We were just talking about it before it all began, and I'm very jealous of her ability to kind of step out of the office and really get into the thick of things. So without any further ado, it is my genuine pleasure to introduce to all of you Dr. Tiffany Xiang. Dr. Xiang, the floor is yours.
Thank you very much, Professor Andrew, and good morning, everybody. Thank you very much for attending this presentation. I also, before starting, I also would like to thank the Center of Khmer Studies for inviting me to participate in this webinar, because I'm very happy to be here and to share some result of the research with you. I also would like to thank again Professor Andrew Murtha for moderating this session, because I think it's night in the United States, so it's not so easy. So my name is Tiffany Xiang. I'm a postdoctoral researcher in social science at the Institut Pasteur du Cambodge. And I'm also affiliated with the Laboratoire Développement et Société at the Paris-Sorbonne University, Panthéon-Sorbonne University, and also affiliated at the LIMEP. It's also a laboratory at the Paris-Saclay University Alliance in France. And so now, like Professor Andrew introduced before, I'm working on public health education with a focus on perception, practice, behavior related to disease, medicine, healthcare, and mainly in a rural and semi-rural context, even if I try to move to some urban for best comparison, but most of my work is related to rural area. So I would like, now I will share the slide with you. I'm going to present here actually the result of field work that I conduct previously during 2023-2024 in Takeo province. So in Cambodia, has a part actually of Ramses project, because it's actually a complementary study of the Ramses project. And the Ramses project means actually resistance to antimicrobial, socioeconomic factors, and regulatory factors influencing emergence and dissemination in the south. And it's focused more on antimicrobial resistance, or AMR. It's a term that you will hear a lot during the presentation, or antimicrobial resistance. So this presentation is actually at the intersection of geography, sociology, anthropology, and public health, and aims to better understand how community respond to disease and what their fear are and how they use antibiotics, because we focus more on antibiotics, and but I will explain to you after that, and under what conditions these practices are integrated into everyday life of people. So actually, it is important to know at the beginning what is AMR. And now AMR is actually considered by the WHO, the World Health Organization, actually, to be one of the major health challenges of our century. To put it plainly or simple, it is a phenomenon whereby some bacteria or pathogen become resistant to medicine that are supposed to eliminate, remove them, and mainly antibiotics. And this means that infections that were once easy to treat can become very dangerous and even deadly for some population, particularly vulnerable population as children. So this phenomenon is global. It affects all the regions in the world, including high-income countries. It's particularly serious consequence in low and middle-income countries, such as Cambodia, where actually access to diagnosis, quality care, and even the strict regulation of drug is still very limited. It's still a challenge. So in addition, antibiotics are still widely available, and we can purchase it without any prescription in local pharmacy. So this is one of the challenge. And also, and what's interesting me in this study is actually trying to understand how people live their disease in their daily life, and how they make decisions about their treatment, their care pathway, and above all, how antibiotics are actually used and perceived in household. But I will not talk about resistant bacteria or drug molecule or something so scientifically so high, but I will rather try to explain the social, economic, and cultural factors that influence how antibiotics are used by communities. So why we choose Cambodia? There are a few points of context that I think we should highlight. So firstly, because Cambodia has undergone a rapid transformation of its healthcare system over the last few years, maybe you know it, especially this 30 last year, because before that we have the, for 50 years, because before that we have the Khmer regime. And now both public and public health center and private clinic, independent pharmacies, street vendor, hospital, various level of hospital, and even informal practice that have been passed on from family generation to generation, including health traditional healer and even illegal drug seller. So we have a lot of medicine providers, something like that. And so what we see is that people do not necessarily follow a standard healthcare pathway. So they move from one provider to another, sometimes in parallel, sometimes depending on their budget, trust, just what is closest to their home, most accessible actually. So this diversity actually creates flexibility in both the supply and chain and demand for healthcare, and there is a lot of variability in the care that people receive, and some receive advice from healthcare professional, others treat themselves, it's a self-medication, or take what their friend or family recommend. And this situation shows that people adapt to everyday constraints and reflect a resourceful, responsive, and sometimes pragmatic approach to health issue, actually. So this is why we think that Cambodia is a very interesting place to study AMR. We can observe how individuals appropriate or do not appropriate antimicrobial medicine in a context where biomedical information coexists with other form of knowledge and other way of thinking. So just a short presentation of the Ramses research study, because it's the context, the content of the study, of our study. So the Ramses project, which this study is taken, is a research project coordinated by several partners, including Institut Pasteur du Cambodge and CIRAD. It was initiated by the Avicent Network, and the overall objective is to explore the social, economic, and institutional factors that influence the emergence and spread of antimicrobial resistance in several countries in the South. So the project is actually implemented in 6 countries, as you can see, in Cambodia, Ivory Coast, Madagascar, Burkina Faso, Laos, and Iceland of the Western Indian Ocean. And they are using a comparative and interdisciplinary approach. And it is also based on One Health approach. Maybe you have know this concept. It actually means that it takes into account the connection between human health, animal health, and environment. So you take all the parts that include the health context, actually. So in Cambodia, we worked on work package 1 and 2 on regulatory issue. We also work on work package 4, which focus specifically on healthcare practice and antibiotic use in communities. And we also work on work package 6 and 7, which focus on assessing laboratory capacities in the country. But here we will leave the work package 1, 2, and also the work package 6 and 7 aside to focus more on work package 4, which is the basis of our study. So the idea is actually to start with the community, listen to people, see what disease they have, how they experience the disease, and how they treat themselves in order to actually better the possible option for action. And it's a way actually of connecting scientific research with the real life experience and developing a response that is more in line with reality, local realities, actually. So the study, as I explained to you, actually the study for the work package 4, so for the Ramses, start in 2022 and finish in 2024. But the field work actually take place in 2023. In Takeo province in the southern Cambodia, so not very far from the Vietnamese border. We would have linked to expand the study, but I must confess that financially speaking, it was a little more complicated than expected. So we just restrained our study on Takeo. So in any case, 3 types of localities representative of different contexts were selected. Like I explained you, we went to 3 places. So Dantal, and also and specifically in Snau village inside the Dantal city. It's actually an urban center.
We also go to the district of Tramco, specifically on Chotil village, which is a semi-rural area. And we also go to Trang district, and specifically on in Presendijk village, which is a very more isolated village, more rural. The aim was actually to compare practices according to the environment, access to service, role of health structure, and type of roles, etc. And so we conduct actually 75 semi-structured interview with women and men between age of 18 to 80. And from different socioeconomic background and with different level of education, we also select several profiles that likely require more healthcare, such as pregnant women or elderly. And the interview were actually conducted in Khmer, but we need to translate it for the analyzing because we use a thematic coding framework and we use a software, and the software does not support Khmer language, which is a pity. So we need to translate it in English. So at the same time, we also took some photo of the pharmacy kit in 21 household. The medicine are in the box or bag, and that family keep at home. And we asked them if it is possible to take some picture of it. And actually, this photo gives us a more concrete idea of type of medicine stored in homes, their origin, their condition, their actual use. This approach is really useful because it combines actually detailed qualitative data with a practical observation of daily life. And we also try to use a statistic to get a broader view of information we collect. And for example, by quantifying the symptom mentioned by a participant, how many times they use a particular healthcare facility, and how antibiotics were used for different health issues, for example. But I will show you the result and the graphic after that. So before presenting the result, I would like also to give you some information about the people that we met and interviewed. So out of the 75 participants, we found 76 percent of women, and the majority of the participants were between 30 and 60 years old. It's quite actually very difficult to convince younger people to participate in the study, especially around 20, 18, 19, 20, 25. This was very difficult. They seems to not very interested, and we cannot push them. So also 47.9% had a maiden level of education, often middle school, high school, something like that. And only 10% had an HEF card. It's actually a social assistance card allowing people to have a free access to public health healthcare, to free public healthcare, actually. So actually, the overall representation of women can be explained by the fact that many Cambodian families, it's actually women who take care of the health of children and elderly, and they make decisions about healthcare and buy medicine at the pharmacy for the household. And when I brought up the topic of health, the men actually always referred me to their wife or their mother, even their daughter. And they are also the one who manage the household finance and know how much money is available for health, decide whatever to go to the clinic or to buy pill at the market, the pharmacy, etc. So men are actually included in the sample, but they are often less willing to discuss their healthcare practice and had less access to formal healthcare actually. And some, however, speak very much. They talk about health very much, but they are mostly head of the household or because of the death of their wife or because they live alone with children or separate from their family. So that's why they are more talkative about it. So the sample design allow us to different participant profile actually, and taking into account social status, age, gender, etc., in order to obtain a more broad representation of certain family reality in the region. And okay, so let's move to some finding. I think it's more interesting because the time is running. So when participants were asked about their common health problem, several types of symptoms came up very regularly, especially Fabry syndrome, such as fever, dengue fever, cold, flu, COVID-like syndrome, flu-like syndrome, etc., etc. And the second is actually the internal pain with headache, joint pain, backache, something like that. The third is gastrointestinal disorder, and so diarrhea, something like that. And among the older people, we know that cardiovascular problems were often mentioned, like high blood pressure, diabetes. And oh, sorry. And this gives us a general overview of what people are experiencing. And we actually went further and asked people how they perceive their disease. And we actually take the fear has a max. And a notable finding was that cancer was very often mentioned as the most feared disease across all the area. So in urban, rural, peri-urban, and this seems surprising because we are in context where other diseases are much more common, particularly infectious disease. Like dengue, malaria, Japanese encephalitis, etc., etc. And some are actually fatal and are untreatable. But finally, it's cancer that is perceived as serious, costly, incurable disease associated with very high pain, slow deterioration of the body, and finally death. And the second most feared disease is actually COVID-19. There was also a generalization of fear of medicine, which it surprised me, which surprised me a lot because some people actually told me that they're afraid of side effects. They're afraid of becoming addicted to some medicine, and the medicine may be too strong for their body to handle. And that actually bring to the question of airborne. In the end, because this way we can ask are they afraid of antibiotic or something like that? But in the end, it was almost never mentioned spontaneously. The concept actually of AMR seems to be very unfamiliar or poorly understood by the community. They're afraid of by side effect, but they still don't really know what's the consequence of AMO. And sometimes we hear things like this medicine doesn't work well for me anymore. My body becomes to use it, but without any explicit link to the idea of bacterial resistance. And this shows that local representation of disease are diverse and complex, and still very aligned with biomedical, and still not very aligned with biomedical definition. And this is a very important information if we want to raise awareness effectively. And let's pass to the second part. So the care pathway. Another essential part of the survey focused on care pathway. What do people do when they get sick? What do they consume? Who do they consult? Where do they go? Etc. This is the meaning of care pathway actually. So in general, the respondent, the majority of people consult a professional when they are sick. Not always a physician in a public facility, but someone. And they seems to prefer to go to private clinic or pharmacy, which is often the first point of contact. They actually perceive pharmacy, for example, has faster, more accessible, more flexible than public facilities. And there is a very little waiting time, and people can then continue with their work or activities after that. Because when they go to public health facilities, they need to make appointment and they need time. There is a lot of queue to go through, and there is a lot of procedure. So people seems to prefer to go to facilities that is faster. So, and we also, there is also the question of trust in local pharmacists or doctors whom people sometimes know for years. So they trust them. So what we note is that the public center were often used more by people who hold an HES card or because it's free, so a lot of people still go to there. And for a hospital, which have several levels, if you don't know, you have a district level, provincial level, and national level. A national level is like Khmer, for example, in Phnom Penh. And people used to go to there when the symptoms are very severe. So, another point is that men consult less than women. And like I told you before, and some say they prefer to wait and see if they get better, and or to go to get medicine without seeking medical advices. So finally, it is notable that traditional practices were rarely mentioned. We did not see or hear anything about any ritual or belief in during the survey, or just very few cases, 3 cases of traditional births where they search for 𝐀𝐻𝐿. 𝐀𝐻𝐿 is a traditional birth midwife or also traditional healer, but they seems to talk about that from the past, 10 years ago, 20 years ago, or something like that. But recently, there is a very low case of traditional healer. So, and it is not a lack of asking, because actually they still exist, but we think that maybe the healthcare is very strongly biomedicalized, and even the medicine can be purchased with a prescription. So maybe it's why there is a decrease of traditional healer. And for illegal drug seller, I'm thinking particularly to local grocer who sometimes sell pills without any regulation. There are a few, but I must have to come across 2 or 3 cases for all the people that I surveyed, but so very low case. So this actually reflects a modern approach of therapy in Cambodia, where the use of medicine is deeply rooted in everyday social practice, actually. And so the third part, the antibiotic use and perception. So antibiotics are a very important part of Cambodian healthcare, but they use a lot of, they are actually used of different way for that. So what the result show is that on the 52 out of 75 participants had used actually antibiotics in the past 12 months before the start of the study. And antibiotics were used for most likely for injuries, including wounds, minor cuts, very, very superficial cuts. The people also use for internal pain, back pain, muscle pain, so like a painkiller actually. That is not the right function. And we also note that they use for febrile conditions such as a fever without any clear diagnosis, and for respiratory problem. The most commonly reported molecule were actually the amoxicillin or an ampicillin, and because they are perceived as effective drug and sometimes miraculous, as they enable faster healing. Another example that I can tell you is a woman that told me that she had taken amoxicillin to make the pain go away. And it is clearly shows that antibiotics are being diverted from their original biomedical function to become a painkiller. And more ambiguous use were also not like people took some yellow pill or white capsule without knowing the name of the medicine, but they know it's antibiotic, but the molecule why or something like that. And very often, the purchase was made directly at the pharmacy based on advice or a habit. Some neighbors or family member recommend a particular medication. Often practitioner actually had given a prescription, but the tablet were not all used, which is quite uncommon in Cambodia since medication are actually sold in a per unit basis. And this may mean that the prescription was not taken in full, or even if everyone say that it was, that they follow the prescription in full, etc. And so it's happened, but we also have some case of precautions that people make purchase for future use, which is also explain the leftover of medicine. And so there is a very few case of pure medication actually. All the people that interview with always seek advice from a third party. So it can be said that residents are not acting out of reckless or they are not ignorant. They are rational, they are seeking effective, rapid, and low cost treatment So in the context where consultation are sometimes perceived as long, expensive, difficult to access, pharmacy, for example, become a very pragmatic solution. And we also found that use increase with age. This is important information. For example, with 48% of people from 80 to 34 to use antimicrobial. For the range 35 to 55, we found 71%, and over 55 years old, the person is 87.5%. So it's very right. So it's a very high person. So the older the person, the more likely they used antibiotic. So another interesting aspect, this is the last part. Another interesting aspect of the study focused on medicine management at home, actually. What do people keep at home? Where do this medicine come from? What do people do with their leftover medicine? In the 21 first kit aid that we take pictures, an average of 10 type of medicine were found per household, actually. So it's 2.4 in which were antimicrobial, and 57% of household actually owns antimicrobial at home. So household in urban area generally store more medicine, including a higher proportion of antibiotic. Most of this medicine came from pharmacy or private clinic. The medicine often originates from Indian laboratory, more than 27%. And the second is Jordani, which was surprising also. And the local production remain actually around 10%. So it's not very high. Medicine are stored in a plastic box, as you can see on the pictures. It's also in a bag. And sometimes it's suspended on the roof to prevent children from reaching them, or sometimes in drawer next to condiment or television, like you can see here, in a plastic bag in the corner of the table. So there is a strong rejection also of expired medicine in all area. So urban, not urban, etc. Even the medicine is still good. If the expire date is very close, participants tend to say that they stop taking the medicine or do not plan to take it. The reason given are fear of side effect. It is not even the effectiveness of the loss of quality of the product, but a potential danger because the thing is dangerous. So to the regard of the disposal medicine, 59% of participants said they keep leftover medicine, 70% threw them in the trash, in the environment, on the ground, in the water, everywhere. And the 14% burned them. There is therefore a real need to raise awareness about post-consumption management, as current practice can lead to environmental risk actually and further misuse. So factor influencing practices. The use of antibiotic is not actually randomly determined. It is structured by specifically social factors. The first factors is actually the gender. As I mentioned, it is often the woman who take charge of the health of the family. They go to the pharmacy, ask questions, choose, administer the medicine. The second factor is actually the household economy, because medicine are chosen based on their price, but also the expected duration of effectiveness. Because if it's very, if you heal very fast, so it's cheaper. So the third factor is a social network, because people used to consult or ask advice from family members, especially if they perceive them as educated, experienced people that they believe in. They carry actually a lot of influence on them. And we also note that self-medication is not widely practiced. Many people say they consult a professional or healthcare provider when it is possible. And so there is therefore a logic of rational, pragmatic management, not massive consumption of medicine or antibiotic in community, even if there are a lot of misuse. So practice are adapted to the constraint of resource available. So another part is when we ask directly about antimicrobial resistance, MO, response reply are often unclear or limited. Most people were unfamiliar with the term. They don't know what MR means. They told us, some people asked us about the word TNAMPSA, is if it is what we mean. Actually, the term is very interesting itself, because yeah, antibiotic in Khmer is TNAMPSA. And TNAMPSA, if you translate it word by word, that means medicine to cicatrization, to cicatrize. So that that put some people to confuse, actually, because actually antimicrobial antibiotic yeah has an effect on bacteria, but it's not for cicatrization. But the term in Khmer, if you translate word by word, means that it's for cicatrization. That's why maybe some people use it on their wounds. So another part, I come back, that author has heard about the medicines that no longer work and say their body was used of it, so they are aware of it. But nobody or very few make the connection with bacterial resistance. And some believe that the resistance is not is from their body, actually, because their body is becoming stronger, and they don't link it with the bacteria. And on the other hand, fear of side effect was very much present. They are afraid of, they seems to mention, they mention some side effect like stomach ache, dizziness, fatigue, etc., etc. And this actually elements that could actually serve as starting point for more effective communication of AMR. Because while the term AMR mean not a lot of things for people, saying this medicine may no longer work if you take it often, may be a better understood for people. So this suggests that that awareness message should be adapted to local language, fear, and perception of people. So based on this observation, we can have several recommendations that can be explored. And the first actually concerns raising awareness in community. As we see there is a fear of side effects from medication. So people are not totally unaware, they are not ignorant. They may just lack some vocabulary to express it. It is therefore possible to establish a name or message using simple term that is more suitable to different profile, which would enable to reach more people. And it is also important to take gender and age into account in information campaign. We don't communicate in the same way with a more elderly person or a young man. As we saw earlier, it is most of older people who take more antibiotics than younger people. So I think it's important to diversify the material supporting the message. The second point is actually managing medicine at home. Store medicine are sometimes poorly identified, as we can see. People do not know exactly why they should take them. So we see the effectiveness. They only see the effectiveness. Either you get better or either you don't get. So it should be good if a healthcare professional took a little more time to explain this function. But I know that they are very busy. And thus, but it can avoid misunderstanding or speculation, which are then repeat and spread through the village or family in the form of advice. And we can also, they can also promote some simple practice like noting the date of the purchase, checking the expiry date, etc., that could reduce some risk. And the last point is actually the role of pharmacy. They are very popular, more than some hospital actually. So improving the skill of this actor, especially in rural area, because we still lack some physician there, would be a quick and effective way to limit overuse of medicine actually. And of course, like any study, there are some limitation to keep in mind this study. First, it is only a qualitative study, even so of data quantitative based. So, and we only conduct it on one province. So it cannot represent the whole Cambodia or provide a generalizable statistic because I work in Pasteur Institute, and most of the times they ask me if it is possible to generalize it, and no, for this study it's not possible to generalize it because it's only one province, so it's some case actually. So if we want to more information on the over all the country, we need to go to all the country actually. And second, there was another representation of women in this study, which even if it reflects this important role in healthcare, but there is a limit gender comparison because we more not a lot of men in the study. And for the third limitation, and is that we that I cannot directly interview healthcare professional or medicine seller in this place. But I think it could be explored further in the future, particularly with regard to the use of antibiotic in livestock farming, for example, because actually in agriculture part, in farming, people use actually a lot of antibiotics too. And in the other hand, thanks to this study, we were able to analyze practice in 3 different communities in detail, see how closely they correspond to the real life, and really draw an experience that are really had actually. And so the study maybe for the perspective maybe extend to another project. Like I told you before, that maybe a national study, which is actually currently being set up in the RACSMate project, which maybe you may heard about it, or you can go to the Pasteur website and see it. It is actually a large national study funded by the Wellcome Trust and led by the Institut Pasteur du Cambodge. And to conclude, this is a pilot study that shows that antibiotic resistance cannot be addressed only as a biomedical or regulatory issue. There is also social, economic, cultural issues that affect everyday life, gender relation, inequality in access to healthcare, and a way to trusting medicine. And people are neither passive or ignorant. They actually adapt to the reality of their everyday life, actually. So thank you very much for your attention. And just a last word, I would like to thank the people and the institutions that make this work possible, especially the Center of Khmer Study for Khmer Studies, not only for the financial support, but also for its broader mission of promoting research on the humanities and social science in Cambodia. And my thanks go especially to my thesis supervisors, so Professor Michel Anterne and Professor Manuel Franck, for believing in me during until the end, even when I myself had totally lost hope for my research career at the beginning. And thank you to the Institut Pasteur du Cambodge, which welcomed me and support the study in everywhere, the CIRAT, which initiate this project, and the Ramses teams. And thank you also for to all translator, driver, field assistant, all the people that ensure the smooth logistic of all the travel. And of course, I would like to express all my gratitude to the people of the village that we visit in Takeo province, because they agreed to participate in the studies, to share their daily experience, answer all the questions that take a lot of time because we ask, etc. So, and thank you for your attention once again. Thanks again to the Center for Khmer Studies, to all the partners, of course, and thank you, Professor Andrew Mehta, for moderating.
Thank you very much, Dr. Xiang. This was a wonderful presentation. There's a lot of material, but it was presented really clearly all the way from, the initial research goals to the methodologies to the different sets of results. And even somebody who's a layperson like myself can appreciate and some of the conclusions that you came up with, I was able to anticipate as well. We have a bunch of questions, and so what I'm going to do is, even though I'm from Johns Hopkins, I'm not from the medical side of Johns Hopkins. I'm from the School of Advanced International Studies. So I'm more of the social scientist than the medical professional. So I'd rather cede the floor to those who have questions, and luckily some of them also overlap with questions that I would have had. So why don't I go to the first one? If it's okay, I'll read it to you.
Yeah, no problem.
Okay, so the first question, the person asks, my experience as a healthcare provider, most patients that this questioner saw did not know what types of drugs they were taking. The only drug that they really had much familiarity with was paracetamol. Am I even though I'm pronouncing it incorrectly, can you understand it even with my terrible pronunciation? The person continues, it's interesting to see many people recall their use of antibiotics in the first 12 months of your study. So I guess the question is, did this person's experience in any way kind of match up with your own?
Can you repeat the question, please?
Sure. Well, the question is that this person asked that said that most patients that they saw did not
Okay.
know what types of drugs they were taking. Is this did you see any evidence of this?
Oh yeah, actually, when we talk with people, yes, the first actually when we interview people, the first reply that they give us is they just take paracetamol. It's true. A lot of people talk about paracetamol, even if it's ibuprofen actually, but they talk about paracetamol. But they talk about when we talk about NAMSA, when we use this word, they immediately know what is it. So because before that I use antibiotic, I try to not use the word, the local word, etc., etc., but they don't understand anything. But when we talk about NAMSA, automatically they seems to know what we mean. And they also show us the sachet, the bag where we can see the medicine. So because I go to the house of the person, so and the person told me that wait a little bit, I will go to take my medicine for you. You can see, but I think it is Tanamsa. And when they give it to us, it is effectively antibiotic actually. And but they don't really know exactly what is a molecule apart ampicillin, but they told it ampi. They use the local name. And amoxicillin, they call it amox. Ciprofloxacin, they use it cipro with a Khmer accent. And this for this they are aware of it. They are aware of it. Actually, if you ask them just uh, 5 minutes or 10 minutes at the beginning of the conversation, they just stop at the painkiller. So most likely they told us that they use paracetamol or only that. But if you stay with them during 1 hour, 2 hours, you come back the tomorrow and you re-ask them, and then they yeah. If and the most important thing is if you use the right word. If you use the right word, they immediately know about what we want to talk about. Apart from the term antimicrobial resistant, because they don't understand what is that. I think they don't understand the mechanism. They are aware that there is something, but they didn't have enough vocabulary to explain it.
Great, thank you very much. Let me go to the next person who's got a number of different questions. Um, uh, I'll try to kind of separate them a little bit. So the three questions here. The first is to what degree are doctors treating biology and physiology versus patient psyche and expectations? The second question was, what is the relationship between lab results for gram stain / culture and sensitivity and the antibiotic ABX prescribed and dispensed? And then the third question is, why were prescribing doctors not interviewed for the study?
So I will reply to the last question first. Actually, we would like to interview them too, but how to explain it? Some of them were very busy. So they seem to not really want to reply to us. So I think it should be very difficult to push them because they don't know us, and it's true, they were very busy because at that time when we went to the site, there is a lot of events, marriage, Khmer New Year, everything. So it was very difficult. And another part is that when we design the study, actually the prescriptor are included in another work package. They're included in another work package, and for me, I only have to manage the work package that is related to community, and in yes, in institute or science or something like that, there is a very limited there are like a barrier that we cannot because actually for this study we have to submit to the ethics committee. Because it's related to health, and most of the study related to health in Cambodia, if you do it in the right way, we have to submit it to the ethics committee. And we base it on the protocol and something like that. And we don't put on the document that we will interview prescriptor. Because of that, actually, if you do the right thing, you cannot interview people like you want, because it's not like before that 10 years ago that you can go anywhere like you want. When I study during my PhD research, actually I can study everything because it was on transformation or something like that, so it's a very broad topics. But when it's related to health, there is a lot of restriction. We cannot do what you want. So because we haven't put it in the ethics committee, it is one of the barrier. We cannot do more. And the second part is, like I told you before, doctor seems to not do not have time at that moment. That's why I explained it after that maybe in other project, in other future study, it should be nice if we can focus more on the provider of healthcare actually. And for the other question, so to what degree the doctor treating biology vicious passion, pizza, and exploitation? Actually, for the first question, I don't really understand what the author means.
My read of it is that the kind of what is the to what degree are doctors treating the kind of the on the one hand the kind of the biological physiological parts of the of the treatment versus the kind of psychological expectations
Oh,
of
okay.
the
Oh, yeah. Actually, the physician try their best. Actually, what we because even if we don't interview people in this side, but I also talk with other physician in other side, in other place. And actually, what we observe is that actually physician try their best to understand the problem, the issue of people, but sometimes a lack of time. We have to be aware of it. There is a lot of people, a lot of passion, and there is an issue on human resources, especially doctors. And so sometimes it's very difficult for them to take time to understand all the cliché expectation of the passion. So they try to do it the best as they can. But sometimes they cannot. They cannot. Actually, in the publication, in the future publications that we would like to also share, maybe to submit very soon, we calculate actually the average number of health facility in all the Cambodia and different provinces, etc., etc. And we saw that if we compare with the global average, from the WHO, Cambodia is still very low. It's still under the number. We have I don't remember exactly the number, but it's lower than the global average. So maybe we can, when I publish the paper, we can check it after that. And for the relationship between lab result and gram stain, actually, how can we explain it? All the country actually doesn't have a lab for all the country doesn't have the lab. There is only 10 laboratory in all the Cambodia, 10 or something like that, that can do laboratory analysis before giving antibiotic. Yes, it is a very big issue, and the physicians are very aware of the problem. They try other, because of lab is difficult to they need a lot of resource. They try a lot of other way, like checking biomarker or something like that. They try to train a lot of people as they can. But they also mention that the lack of training, and they need it, and so they are aware of the situation there.
Okay, thank you. That actually anticipates the next question, which is what structural changes in health education, supply chain, or regulation do you believe are the most urgent to improve antibiotic practices in rural Cambodia?
Actually, we have regulation. I also went to the Department of Drug and Food from the Ministry of Health in Cambodia, and there are actually a regulation. And we also check the regulation with a pharmacist, with an intern, because I'm not really a specialist on pharmacy. So I work with an intern who is a pharmacist to check it from France. And she checked all the documents, and she also told us that actually the regulations are very similar with France. For the pharmacology regulation rule, something like that. There are a lot of documents, and these documents are actually available on the website too. You can download it on the Department of Drug and Food. Some are in Khmer, but they are also translated in English, actually. But the problem is, and they recognize it, that they only have 30 agent to check all the country, no, 13, so less than 20, to check all the pharmacy, the agent, it's like inspector. It's like inspector to check all the pharmacies, all the lab production for all the country. What can they do with only 13 people to check, to inspect all the pharmacies in the country? They lack of human resources, and they are really aware of it. And so sometimes they told us that actually to help them, they asked some people from the province, from the public health department to help them, or the ministry to help them, because they cannot do all the work, because it's only a small number. So, but we have to understand that actually the another specialty inspector is not easy actually to do. It's a big job. So for the regulation, actually, if we ask if Cambodia have regulation, yes, there is, but for the implementation, it's the practical the action actually is It's another question. Okay.
That's it's very sobering. It reminds me of some of the things that I found when in local levels when I was doing research in China some 20 years ago or so. We were really talking about those types of numbers to implement kind of these larger programs, and it really becomes a question of how does anything get done. Um, I have plenty of more questions. This person has two. And I should also say that they're all preceded by thank you for your wonderful work and your presentation. So I kept that. I didn't include that, but maybe I should have. So the two questions here are number one, among the participants that used antibiotics, were most of them prescribed by healthcare workers, or did some of them ask specifically for antibiotics from the pharmacy or HCW? And then the second question is, you mentioned about trust on choices of healthcare seeking behavior. Can you elaborate more on the question of trust?
Okay, so the question of trust, actually, how can how can I explain that? Trust is like it's linked to the acceptability, the acceptance of the treatment. Actually, if people don't trust the system, don't trust the person that provides the care or something, or provides the advice, it's very difficult for them to take the treatment. And sometimes they only take the treatment just one pill before you, but after that, they don't use it at all. So trust is a key. Trust in is a key for the acceptability, the acceptance of the treatment. So I don't know if I will reply to your question. And for the other study, for the other question, could you repeat it actually?
Right. So among the participants that used antibiotics, were most of them prescribed by healthcare workers? Or did some of them ask specifically for antibiotics from, say, the pharmacy or HCW?
Actually, the antibiotics are prescribed. Actually, there is a lot of a case, like I explained to you. Sometimes, most of the time, it's prescribed by healthcare workers, so the physician or something like that. But some of people still keep the prescription or the box or something like that if they can, and after that, if they think if it's run well, it's work well, they keep the prescription, they keep the document. And after that, for when they develop another the same symptom or something similar in other months, they show the prescription, even with with it's not yes, they show the prescription, or they show the box, or the plaquette is yes, the plaquette, because sometimes they can buy the plaquette, and you have some word around it, and they show it to the pharmacy, and so they ask, can I have the same thing? So so we also have this case. Another case is that they go to pharmacy, and they ask the advice from the pharmacist. Actually, they and most of them do that. Actually, it's they ask the advice from the pharmacy. They told them their symptom, or the symptom was a member of the family. I cold, I have fever, I have pain, or something like that. They describe everything, and after that, the pharmacist gives them the medicine. They give them, and sometimes they give them namsam. Namsam, it's a mix of medicine, and sometimes include antibiotic too. So it's like bag, And in this bag, you have painkiller, I don't know how many antibiotics, you have also vitamin, you have a lot of things, and they give you the bag, but you don't know exactly what is included in the bag because it's and in this case of Tanampsom, you don't have the name of the medicine on the bag. You don't have anything. You only have pill in the bag. So
Let alone the
this
dosage.
is yeah, so you don't know exactly what is inside. So I think it is also an issue, and actually the authority also aware of it. The time sum is a really a big issue here.
Well, the question of kind of regulatory dimension brings us to the next query, which is how do we address the ethical dilemma of denying people access to antibiotics through stricter regulation when there are no affordable or accessible alternatives in their community?
Um, Very difficult question actually, because I'm not the authority, so I cannot reply for them. But I think regulation can actually it's not only the evolution of only regulation; it's all the system that have to be improved, and they try to do it now. And but like for example, to have you know that in a lot of country now they develop uh, the okay, the documentation of your previous disease. I don't know how to explain it in English. Uh, yes, a file that all the physician can access and to see what you had, what you had, what disease you have, what where you go to access to care, something like that. I think the yeah the one of the priorities is to develop it, because if we don't have the past of the people, it's really difficult, because sometimes you go to see the physician give you, for example, some antibiotic, and you think that the physician is not really relevant and not very nice. So tomorrow you go to another physician, but the new physician doesn't know that you previously go to another person previously, and so you have two prescription. What to do with that? So I think one thing that they try to develop, but I don't know when it will work.
Okay,
And
oh, go ahead. Another question is, do you have any thoughts on, or can you comment on this aspect of the Cambodian healthcare system? Is there a component of health, wellness, and prevention, or is there a reliance on medicine with a more kind of passive patient approach?
uh, sorry, I'm searching your education now, but can you repeat it?
Yes, yes. Is there a component of health, wellness, and prevention, or is there a reliance on medicine with a more passive role for the patient?
Mm, I think they are trying to work on it, because actually AMR in Cambodia, the topic of AMR only developed in 20 yes, in 2012. Yes, they begin to start to discuss about AMR only in 2012. And after that, there is some document. They create a technical working group. They create some initiative, etc., etc. And but most of the initiatives are related to hospital, healthcare worker, because it's normal, it's a ministry, so the ministry work with their collaborators, their close collaborator first. So I think that in the future they will extend it to community, but now they have to develop at the ministry and at with their close collaborator first, but maybe in the future, yeah.
I'm going to just slip in one of my own observations or questions, which are not as learned as the ones that you've already gotten. But I found it really interesting the degree to which, in one of your findings, that people did not seem to rely much on kind of local kind of healing practices. My my real research focus is actually China, not Cambodia. And in China, I find the opposite to be the case, where kind of
Oh.
local and and particularly traditional Chinese medicine is something that is very much a part of
Mm-mm.
any treatment. So I thought that that was an interesting finding on your part, just from a comparative perspective.
Um, yeah,
It's not
I
it's not
actually,
real. Oh, go ahead.
yeah. I understand what you mean. The what I mentioned before, that it is only a case of Takeo. That
Mm.
maybe if we go to another province, maybe more traditional used of maybe for Singapore, for example, maybe the situation may be not the same. Huh? Because actually Takeo is situated not far, it's on the border of the Vietnam. It's on the two main road, two national road across the province to Phnom Penh, to the border from, and also to Kampot and to the main port at Sihanoukville. You have so there is a lot of activity. It's not so far from Phnom Penh too. It's only 1 hour. No, not only. It's 2 hours from Phnom Penh, so it's not so far. So maybe this can that why the situation is like there. And also there is a lot of migrants, actually a lot of young people uh, move to another country or another province, because during a long time this province now it's developing more because you have farming, you have a lot of activities. They move some factories from Phnom Penh and Kanda province to Takeo, etc. So maybe the situation will change. But maybe I think that if we go to another province, we may find other findings, I think.
Thank you very much. We have one question left, or actually we have plenty more questions, but we only have time for one more. So,
Yeah.
um, so the question is: there was a study conducted in 2016 by Professor Chorvan on
Yes.
on Cambodian physicians' perspectives on antibiotic prescribing practices. And the study found that inappropriate prescribing was common and that not many of these physicians had sufficient training on infectious diseases. But that was 10 years ago. And the person concluded by saying, I think a lot has changed since then. I what would would you agree?
About that there is inappropriate prescription.
Know that a lot has changed since then.
Oh, yes. I think there is a lot of change because, like I previously told you, that now it's a priority. It's one of the top priority for the government too to to work on this topic. So maybe when Dr. Chawan, actually I met them for the study too. I interviewed them, I interviewed him also because he is one of the first person that work on it for academic part and for his PhD. So yes, at the time he did his PhD in Australia. So yeah, I met him too. And at that time, when he started the project, his study, it was a so he started when, like I told you before, he worked with the MDP at that time, and after that with WHO, and this is the beginning of the study. And so I think most of people are not very aware of the problem of AMR. But now, 10 years after, some change because AMR became a very high topic in for the global in global world, and a lot of country invest in this topic, and so now they try to send more message about raising awareness. They are training about it. There are a lot of meeting about it. So people from the ministry are also interested with the impact of that on in communities. So they try to train some provider too, but as I explained you, sometimes it's not that they don't want to do it. It is the lack of resource.
Right. No, I mean there's intent and there's capacity. But while we're on a positive note, I'd like to maybe end on that positive note, and I'd like to ask the audience first of all to extend our gratitude to Dr. Xiang for sharing her research and her results with us. Thank you very much for, it was really an illuminating presentation. And I also want to thank the people in the audience for sticking around because this was a really nice number of people. The questions indicate that you are all quite engaged, and we can't really ask for anything more, in a webinar like this, but for that kind of engagement. So please join me in one more round of applause for Dr. Xiang, and look forward to seeing as many of you as possible for future CKS events, and hopefully you'll also be following the work of Dr. Xiang. So thank you all very, very much.
Thank you very much.